Yeah, hi, good evening, everyone. So, welcome to this last mile for Neet PG 2022 an MCQ discussion session of radiology. Um, we are very few days away from the exam, and I'm sure that a lot of butterflies are there in your stomach. Anxiety must be at its peak. You must be thinking, I do not know what will happen. But I always believe that whatever that is going to happen will happen for the good. And in this session, just give me a sec. Can you give me some thumbs up to check whether the audio and video is fine? Allow me a sec. Just give me a couple of seconds. Just give me a quick thumbs up if audio and video is fine. Okay. Yeah, so I'm sure that a lot of you must be anxious, but all I can say that you people have worked really very hard, and the God always listen, God always watch. That if you have done a real hard work, don't be anxious, and I am really very sure that you are gonna get a great rank. On your behalf, I am planning to visit um, uh, the temple, Lord Venkateshwara temple at Tirumala on Saturday, and I will pray for all of you that you should get the rank that you deserve. You should get a rank on the basis of hard work that you people have done over a period of time, and your hard work should not go waste. If anybody wants to pay his or her regards to the Lord, do let me know, and I will pray on your behalf in the temple. Uh, so now in this session we're gonna talk about some important topics of the radiology that are very frequently asked in the exam, and you can expect to be asked in the exam, which is few days away. So, and also, I want to tell that please don't be anxious. Please don't be nervous. The only and the only thing that you have to do is whatever that you have read, you will have to make sure that you are utilizing that in the exam. And if you're able to do that, you are going to get a very good rank without a doubt. Okay. So I'm going to show you some very simple topics which are frequently asked. You all have done, irrespective of the platform that you have studied, you have gone through all these topics. If you have not gone through that, again, don't let a FOMO come to your mind. You people have done really great work, and you will be able to do a justice with that. Okay. So This is a standard question that we commonly get in the exam. So the purpose of giving you this particular question is that if you are missing it, you have to make sure that you are able to do this without a doubt. A 55-year-old male having bone pains for the last 2 years present with the image as shown below. What is the most probable diagnosis? And you are getting an image. This is a typical question from the radiology that you are getting in the exam. That what are the various shapes of the skull? Is it a multiple myeloma or a Paget's disease or a hyperparathyroidism or an eosinophilic granuloma? So this is a typical punched out lytic lesion. Punched out lytic lesion. Now, which is also called as, sorry for that, which is also called as raindrop appearance. Punched out lytic lesion or a raindrop appearance. It's a blunder not to know this. So this is multiple myeloma. So let us quickly go through the important shapes. I have all these 1-minute radiology revision series on my YouTube channel. And if somebody has not read radiology, you can quickly go through those 45 videos as a binge watching now. And I'm sure that your radiology will be complete with them. So what are these? This is a punched out lytic lesion, which is called as a raindrop appearance, seen in multiple myeloma. This is a geographic lytic lesion with beveling of the edges, which is a feature of eosinophilic granuloma. This is silver beaten appearance. Just give me a sec. This is a silver beaten appearance which is seen in raised intracranial tension. Okay, there is an interesting question that I want to ask you over here. Give me the answer in the chat. What is the earliest feature of raised intracranial tension in children? What is the earliest feature of raised intracranial tension in children? Okay, question number 2. What is the earliest feature of raised intracranial tension in adult? I am talking about the radiographic features. Earliest radiographic feature of raised intracranial tension in children. जल्दी से बता दो. Earliest radiographic feature of raised intracranial tension in adults. So in children it is sutural diastasis. In adults it is erosion of dorsum sella. In children it is sutural diastasis. In adults it is erosion of dorsum sella. And now the real question for you is, anybody who can tell me what is the earliest radiographic feature of raised intracranial tension in older children? What is the earliest radiographic feature of raised intracranial tension in older children? So please remember, in older children it will not be sutural diastasis, it will be erosion of dorsum sella, because the moment I say it's an older children, that means the sutures are already closed. Okay, let me twist the question. Please remember, in the Neet PG exam, the major point that you have to pay attention to is the question simple or is the question slightly twisted, like the question that I am giving you right away. Earliest imaging feature of raised intracranial tension in adults. Earliest imaging feature of raised intracranial tension in adults. Give me a quick answer. Let me see who answers it first. Earliest imaging feature of raised intracranial tension in adults. So if you are thinking the answer is erosion of dorsum sella, now you are wrong. It is not erosion of dorsum sella. It is ventricular dilatation. It is ventricular dilatation which can be seen on CT or MR. So you have to see the language, and that is gonna play all the role in the paper. Okay, what is this? This is sun ray, or you can say hair on end appearance. Okay, more precisely true cut or an hair on end appearance, which is a feature of thalassemia. Now this is called as salt and pepper appearance. Don't confuse it with multiple myeloma. In a multiple myeloma you can clearly see the lesion, whereas in this you see multiple dot, which is like somebody has sprinkled the salt. That is called as a salt and pepper appearance, which is a feature of raised hyperparathyroidism. And this is what is called as cotton wool skull. Cotton wool skull, which is a feature of Paget's disease. So cotton wool skull is a feature of Paget's disease. Okay. Second question, a very simple question, but the whole idea was to quickly revise the topic with you. Fallen fragment sign is characteristic of. Fallen fragment sign is characteristic of aneurysmal bone cyst, simple bone cyst, giant cell tumor, and osteosarcoma. It is to be noted that all the four are very, very frequently asked in the exam. So fallen fragment sign is characteristic for simple bone cyst, also called as unicameral bone cyst, also called as unicameral bone cyst. So what is happening is that there is a long bone, there is a cystic lesion in the region of metaphysis. Please remember, if you see a cystic lesion in the metaphysis, only think about two differentials in the exam. Either it's an aneurysmal bone cyst or a simple bone cyst. If the lesion is going beyond the confines of the bone, that means if it is expansile, it has to be ABC. If it's a non-expansile lesion, it is SBC. If it's an expansile lesion, it is ABC. If it's a non-expansile lesion, it is SBC. ABC usually shows fluid level, or what we say is a blood fluid level. Whereas an SBC shows a fragment of the bone which is seen inside the cyst, which is called as a fallen fragment sign. If you see a lesion in the epiphysis, always remember this. If you see a lesion in the epiphysis, always look at the growth plate. If the growth plate is fused, you are dealing with an adult, and in an adult, epiphyseal lesion has to be GCT. If the growth plate is unfused, you are dealing with a child, and if it's a child, it has to be chondroblastoma. Okay, so fallen fragment sign is characteristic of simple bone cyst. So what is this? What do you see over here? You see a metaphyseal lesion which is non-expansile and a fallen fragment sign. So it is a simple bone cyst. It is nothing but a simple bone cyst. On the other hand, you see an epiphyseal lesion. Which is expansile. But expansile does not matter if it is an epiphyseal lesion. The growth plate is fused. After the fusion of the growth plate, a lesion at the distal end of the radius has to be GCT. Period. Any lesion, any lytic lesion at the distal end of the radius, the first answer that should come to your mind is a GCT. If you see a malignant lesion, it usually shows a periosteal reaction, and if periosteal reaction is perpendicular to the cortex, it is a sunburst pattern. It is nothing but a sunburst pattern, which is a feature of osteosarcoma. All right. Next question. A 45-year-old female presented with chest pain and breathlessness in the casualty, and below is the representative CT section. What is the most likely cause of her symptom? Okay, before I go forward, I want anybody who can tell me, is it an NCCT or a CECT? Let me see who can answer this. Is it an NCCT or a CECT? I think all of you can identify it's a CT scan by looking at the vertebrae. Vertebrae are so wide, so it has to be a CT scan. But now you have to tell me, is it a non-contrast CT or a contrast enhanced CT? Is it a non-contrast CT or a contrast enhanced CT? Okay, so this is pulmonary artery and this is paravertebral muscle. Always compare a vessel with a muscle. If the vessel and muscle are of exactly same color, it's a non-contrast CT. If the vessel is white than the muscle, it's a contrast enhanced CT. Since the pulmonary artery is so white, so white in comparison to the paravertebral muscle, it has to be a CCT. But now the big question, this vessel is descending aorta. And this is paravertebral muscle. If I compare descending aorta with a paravertebral muscle, they are exactly same. Then why it's CCT? Why I should not label it as a non-contrast CT? Anybody who can tell me, let me see who is the smart one in the group who can answer this question. That why do I say that it is a CCT, and if it's a CCT, why the descending aorta does not have a dye in it? Why the descending aorta does not have a dye in it? Let me see who can answer this. So descending aorta does not have a dye. Why? Because by the time the dye has been injected and the scan has been done, the dye is not able to travel up to the descending aorta. Because once you give the dye to the antecubital vein, first it goes to the heart. From the right ventricle, it goes to the pulmonary artery, and after the pulmonary artery, after traversing through the lung, through the left side of the heart, it enters into the aorta. So if the scan is done when the dye is present right into the pulmonary artery, you don't see the opacification of the descending aorta. And when the dye is present in the pulmonary artery and you do the scan, this is called as CTPA. CTPA, CT pulmonary angiography. CT pulmonary angiography. That's a typical image of a CT pulmonary angiography. And what do we see is we are seeing a filling defect in the pulmonary artery, and this is an image of a pulmonary embolism. So this is not because of the saddle embolus. This is because that the dye is not able to travel up to the aorta, and the type of CCT when the scanning is done when a dye is present in a particular vessel is called as a CT angiography. Is called as a CT angiography. At this stage, I want to ask you two more questions. What is a preferred screening test? What is a preferred screening test for pulmonary embolism? What is a preferred screening test for pulmonary embolism? Answer is blood test, which is D-dimer. D-dimer. What is the investigation of choice to diagnose pulmonary embolism? Investigation of choice to diagnose pulmonary embolism is CT pulmonary angiography. Is CT pulmonary angiography. All right. So examiners are very fond of asking questions on paranasal sinuses. Okay, paranasal sinuses. Please make sure that if you have confusion between them, you have to know them. You have to know them without a doubt. So Waters' view is the best radiograph for the evaluation of maxillary sinus. Is for the evaluation of maxillary sinus. For frontal sinus, it is Cadwell's view. For frontal sinus, it is Cadwell's view. So let us see some quick images. So anybody who can tell me image number 1 and image number 2, which one is Waters' view and which one is a Cadwell's view? Now let me see who can answer it. Yes. So which view is what? 1 and 2. Which one is Waters? Which one is Cadwell's and what? Yes. Anybody? What is 1 and what is 2? Let me see who can answer this. A quick answer. Yes. Quick answer. Alright, so point to be noted is both are Waters' view. Both are Waters' view. The difference is the first is a Waters' view in open mouth position and the second is Waters' view in a closed mouth position. The first is Waters' view in an open mouth position and the second is Waters' view in a closed mouth position. Look at the teeth. The teeth are approximated to each other. It's a closed mouth view. These teeth are wide apart. This is an open mouth view. So first is open mouth. Second is closed mouth. Open mouth Waters' view is also called as Pere's view. Open mouth Waters' view is also called as Pere's view. It helps us in visualization of the sphenoid sinus through the open mouth. It is to be noted that in the Waters' view, the way to identify is to compare the lucency of the orbit with the lucency of the maxillary sinus. The lucency of the orbit with the lucency of the maxillary sinus is something that you should compare. If the two are equally lucent, the sinuses are normal. If the sinus is opaque in comparison to the orbit, then they are diseased. Okay. So let us see some of the diseases. So what you can see is, anybody who can tell me what's the diagnosis of image number 1? What's the diagnosis of image number 1? You can see a soft tissue projecting from the superior wall of the orbit. After having a history of trauma to the eye and there is a fracture of the inferior wall of the orbit, the soft tissue is hanging from the superior wall, which is called as a teardrop sign. Which is called as a teardrop sign, which is a sign of blowout fracture. Teardrop sign is a sign of blowout fracture. At this stage, I also want you to tell me, anybody who can quickly tell me, let me see who answers it first. Empty orbit sign is a feature of which disease? Empty orbit sign is a feature of which disease? Empty orbit sign is a feature of which disease? Answer is NF1, neurofibromatosis type 1. Because of the sphenoid wing dysplasia, these are the two lines that are seen in the orbit because of the greater and the lesser wing of the sphenoid, and because of the sphenoid wing dysplasia, these lines are not seen, which is called as an empty orbit sign, which is a feature of neurofibromatosis type 1. Alright, so what is the most appropriate investigation to be done to confirm a malignant carcinoma head of pancreas? Most important investigation to be done to confirm a malignant carcinoma head of pancreas. Yes, Milo, the frontal sinuses are normal. They are slightly more pneumatized, but they are normal in the image. What is the most appropriate investigation to be done to confirm a malignant carcinoma head of pancreas? Lower or upper wall teardrop sign? Bache, teardrop sign is because of the fracture of the inferior wall of the orbit, and once there is a fracture of the inferior wall of the orbit, the orbital contents herniate into the maxillary sinus. Okay, so this is a very interesting point, and a lot of people get confused here. So I will quickly revise the entire topic with you in the next 3 minutes. Cancer. So please remember, there are two important things in the cancer, and that is how you have to remember it. The diagnosis of a cancer and staging of a cancer. Diagnosis of a cancer and staging of a cancer. If somebody asks me who diagnose, I will say pathologist. If somebody asks me who stage, I will say radiologist. It's so interesting for DBMCI here. Now, if somebody asks me, I say Praveen diagnose, Rajat stage. And P for Praveen, P for pathologist, R for Rajat, R for radiologist. Okay, anyways. So, alright. So, the point is, now, so how a pathologist is going to make the diagnosis? Yeah? So, by the time you talk about MCQs, your life becomes MCQs, and every time you try to relate to things, every time you try to link the things so that you can recall easily, and that is what you have to do. Okay, so Praveen can diagnose by two ways, either by the cytology, or I will say cells, let me write it cells, or by the tissues. If you diagnose it by the cell, this is called as cytology. If you diagnose it by tissue, that is called as biopsy. Now, in general, biopsy is a better way to diagnose a condition, and the best way to diagnose something is a biopsy. But there are few areas where a cytology is more than sufficient. If somebody asks me what are the two areas, there are many, but if somebody asks me what are the two areas where cytology is sufficient, I will say thyroid, remember one, and the second is pancreas. Now, in a thyroid and pancreas, we prefer to avoid doing a biopsy. Thyroid, because it is highly vascular, I don't want to do a biopsy. It can cause a significant amount of bleeding. For a pancreas, it is usually the retroperitoneal organ is very difficult to get to access. Okay, so how a thyroid FNAC is done? Thyroid FNAC is done usually using ultrasound guidance. How pancreatic FNAC is done? Usually using endoscopic ultrasound. Because I don't want to pierce through the stomach, I don't want to pierce through the other peritoneal structure by going to the retroperitoneum. Okay, so pancreas is endoscopic ultrasound guided FNAC, and for a thyroid, it is ultrasound guided FNAC. Now, for a thyroid, FNAC is usually sufficient. It's a pathology question, but it's very frequently asked that which disease cannot be diagnosed by FNAC in thyroid. You can write it down in the comment section. Which disease cannot be diagnosed on FNAC in thyroid? Answer is yes. Answer is. Tell me the answer. Meanwhile, I will tell you what radiologist does. So, radiologist stage, and there are two important points of the staging. One is a local staging, and the second is complete staging or simple staging. When somebody talks about staging, I will say T, N, and M. Somebody talks about the staging, I will say T, N, and M. T, N, and M. T, N, and M. So local staging majorly means T. So yes, you are correct. Follicular adenoma cannot be differentiated from follicular carcinoma on the FNAC. Very good. So okay, when you say complete staging, it is T, N, and M. And the most important among them is M. Because if it is M, when T and N are irrelevant. If it is M1, T and N are irrelevant. As a blanket rule, the complete staging is done by PET-CT or CECT. As a blanket rule, if somebody asks me, I will say that the complete staging is done by PET-CT or CECT or CCT, whereas the local staging is mostly done by the CT, but in some of the diseases it is different. For esophageal cancer, the preferred way to do a local staging, yes, the preferred way to do a local staging is endoscopic ultrasound. For urinary bladder, the preferred way is MRI. For breast, the preferred way is MRI. So for esophageal cancer, endoscopic ultrasound for local staging. For urinary bladder, the preferred way is MRI, and for breast, the preferred way is again MRI. Okay, so that is how you're gonna do that. So what is the most appropriate investigation to be done to confirm a malignant carcinoma? Answer is endoscopic ultrasound guided FNAC. Endoscopic ultrasound guided FNAC. Okay. All right. Bone tumor is usually a favorite question that is asked in the exam. I have seen a lot of image-based questions on the brain tumor. A 6-year-old boy has been complaining of ignoring to see the objects on one side of the exam, on left or whatever side, on side of the examination. His IQ is normal. His visual acuity is diminished. The radiological image of the patient is shown below. What is the most likely diagnosis? So what do we see? Please see careful. You are seeing a sagittal section, and in a sagittal section you are seeing a mass, and this mass is above the sella turcica. Because it is above the sella turcica, it's a suprasellar mass. Okay, it's a suprasellar mass. I will tell you some tricks over here. Remember, this is sella turcica. Sella turcica contains pituitary gland. Okay, sella turcica contains pituitary gland. If the lesion is above sella, this is suprasellar. Please remember, this is suprasellar. And if somebody asks me what's a suprasellar mass, it's craniopharyngioma. Okay. If it's a sellar mass, it's a pituitary adenoma. So please remember that. If the lesion is seen separate from the pituitary and it is in the suprasellar space, it will be craniopharyngioma. But if it is involving the pituitary, it is a pituitary adenoma. If it is less than 1 centimeter, it is microadenoma. If it is more than 1 centimeter, it is macroadenoma. So if it is less than 1 centimeter, it will remain within the pituitary. It will remain within the sella. However, if it is more than 1 centimeter, it will be sellar as well as suprasellar. It will be sellar as well as suprasellar, and that is why it shows what is called as a figure of 8 appearance. So figure of 8 appearance is a feature of pituitary macroadenoma. Okay. Now a question for you. Investigation of choice to diagnose pituitary microadenoma. Let me see how much hi-fi have you read. Investigation of choice to diagnose pituitary microadenoma. And let me give you some FOMO. Investigation of choice to diagnose pituitary microadenoma. Students are saying, sir, इस टाइम पे क्यों FOMO दे रहे हो? इस टाइम पे FOMO दे रहा हूँ कि नहीं आता तो कोई बात नहीं. That's okay. एग्जाम में आ सकता है. पता नहीं ना, एग्जाम में तो कुछ भी आ सकता है. But the possibility of the other things being asked in the exam is much higher than this. Okay, so MRI is not the answer. I want to ask you which type of MRI. So it is dynamic contrast enhanced MRI. It is dynamic contrast enhanced MRI where a pituitary microadenoma shows delayed enhancement. Okay. Dynamic contrast enhanced MRI where pituitary microadenoma shows delayed enhancement. Okay. But the point to be noted is, the whole point that I want to tell you is that how a craniopharyngioma is diagnosed for microadenoma and macroadenoma is more likely to be asked in the exam than this. Never think that this thing will never be asked in the exam. In a medical field, anything can be asked in the exam, but we should always go with more probability, and a more probability is of other stuff. All right, let us see some more tumors. Quick tumor. I can see a mass which is posterior-superior to the midbrain. And if I see a mass which is posterior-superior to the midbrain, what is it? It is a pineal gland lesion, an enhancing mass in the pineal gland. The first answer that should come to my mind is a germinoma. On the other hand, this is a typical, what do you call it as? Figure of 8 appearance, and which is a feature of pituitary macroadenoma. Pituitary macroadenoma, and this I don't think needs any explanation. Everybody knows it. What is this called as? Sorry for that. This is called as a butterfly glioma. This is a butterfly glioma. And what is this? You are seeing an intraparenchymal mass in the left frontal region. Intraparenchymal mass in the left frontal region with these white spots. White spot on the CT has to be calcification. Has to be calcification. And these calcifications, intraparenchymal lesion, the first disease that should come to your mind is oligodendroglioma. Oligodendroglioma. Yes, Sai, you are absolutely correct. Butterfly glioma is nothing but the GBM, a glioblastoma multiforme. What do you see here? You are seeing a cystic lesion with eccentric nodular enhancement. A cystic lesion with eccentric nodular enhancement. It is very difficult to comment it without the history. If the patient has a history of VHL, von Hippel-Lindau syndrome, this is a case of a cerebellar hemangioblastoma. Cerebellar hemangioblastoma. And if the history of von Hippel-Lindau is not given, then this is a case of a pilocytic astrocytoma. Then this is an image of a pilocytic astrocytoma. Okay. If you see a mass which is showing the thickened meninges which tapers gradually, which is called as a dural tail sign, it is a feature of meningioma. It's a feature of meningioma. And if you see a midline mass between the two lateral ventricle, this is the location of foramen of Monro. In a patient with tuberous sclerosis, this is called as SEGA, subependymal giant cell astrocytoma. Subependymal giant cell astrocytoma. And these are typical what is called as an ice cream cone appearance. Ice cream cone appearance. And ice cream cone appearance is a feature of vestibular schwannoma. Ice cream cone appearance is a feature of vestibular schwannoma. And if the vestibular schwannomas are bilateral, this is a case of neurofibromatosis type 2. If the vestibular schwannomas are bilateral, then this is neurofibromatosis type 2. Okay, type 2. Tuberous sclerosis. But tuberous sclerosis is a very important topic. Neurocutaneous syndrome, if you have not revised, quickly go through and revise the neurocutaneous syndrome. Tuberous sclerosis typically present with a triad which is called as Vogt's triad. Vogt's triad. What is that Vogt's triad? There are three important features. Epiloia is a standard way to remember it. What is epiloia? Epi for epilepsy, LOI for low intelligence, and A for adenoma sebaceum. Epilepsy, low intelligence, and adenoma sebaceum. This is a characteristic triad of tuberous sclerosis. A lot of things that are seen in the brain include subependymal calcific nodule, which are seen as small calcification along the ventricular lining, which is called as candle dripping appearance. These nodules are usually benign, but if they are seen in the region of foramen of Monro, they may undergo malignant conversion, which is called as subependymal giant cell astrocytoma. Apart from this, cortical tumors, which are seen as flare hyperintensities in the white matter, which are heterotropic gray matter, nothing but the heterotropic gray matter, cortical tumors is another important feature of tuberous sclerosis. Apart from the brain, there are many other parts of the body that are involved in tuberous sclerosis. One of an important organ that is involved is kidney. And in the kidney, you are seeing fat containing lesions which are called as angiomyolipomas. Angiomyolipomas in the kidney is a very, very important feature of tuberous sclerosis. In the heart, you see rhabdomyomas. Cardiac rhabdomyomas is another important feature of tuberous sclerosis. In the lungs, you see lymphangiomyomatosis. Pulmonary lamb or lymphangiomyomatosis is another important feature in the tuberous sclerosis. So these are then bones in the form of islands and subungual nodules. There are many other features that are seen in tuberous sclerosis. All right, next question. What would be the contrast of choice in esophageal perforation? So examiners are usually very, very fond of asking questions on contrast. So at this stage, I would like to tell you that if you want to give oral dye or an oral contrast, the preferred contrast is barium sulfate. Remember that. The preferred contrast for the oral studies is barium sulfate. Why? Because first, it is not absorbed from the GIT, and second, it causes adequate mucosal coating. But there are certain contraindications of barium sulfate. So what are the important contraindications? Small bowel obstruction, intestinal perforation, and tracheoesophageal fistula. Now, point to be noted is a small bowel obstruction, because barium doesn't get absorbed, it forms barium stone, and that is why barium should not be used. Please remember the preferred dye for small bowel obstruction is gastrographin. Whereas for intestinal perforation, if the barium will leak into the peritoneal cavity, it can cause peritonitis, and hence again the preferred dye is iodinated dye, which is the gastrographin. In a tracheoesophageal fistula, if you will give barium will go into the trachea and into the alveoli, and it can cause increase in the dead space over there, and that is why barium should not be used. The important point about the tracheoesophageal fistula is if you will give gastrographin is highly osmolar. It is highly osmolar. It will draw water from the pulmonary circulation and can cause pulmonary edema. And hence the gastrographin should be avoided, and the preferred dye for a tracheoesophageal fistula is iohexol, which is the non-ionic dye. But now the very, very interesting point is that the barium is irritant for the peritoneum, but it is not an irritant for the mediastinum. Okay, just remember this particular part. But still, we don't want to give barium for an esophageal perforation. First of all, if it's a peritoneal part of the esophagus that is perforated, it can cause peritonitis. So we want to avoid it. Now, please remember the preferred dye for esophageal perforation is an iodinated water-soluble dye. And out of these four, the only iodinated water-soluble dye is iohexol, and that should be the answer. Now, it is to be noted that the gastrographin can also be used in esophageal perforation. However, if you are suspecting aspiration, then the use of gastrographin is tend to be avoided, because if the high osmolar dye gets aspirated, it can cause pulmonary edema. Okay, but in this question there is no confusion, it has to be iohexol. Gadolinium is an MRI contrast. It's an MRI contrast, and technetium 99M is used in nuclear scan. At this stage, I want to take an opportunity to ask you another question. Anybody who can tell me what is the half-life of technetium 99M? What is the half-life of technetium 99M? Answer is 6 hours. Half-life is 6 hours. And anybody who can tell me what is the energy of the gamma rays emitted by technetium 99M? Energy of the gamma rays emitted by technetium 99M. 140 kilo electron volt. 140 kilo electron volt. All right. Question number 8. Bragg's peak is due to. Bragg's peak is due to. Okay, so what is Bragg's peak? The Bragg's peak is a very interesting concept, and this concept is related to, if you ask me, I will say it is related to radiotherapy. Okay. Now, in the radiotherapy, the common type of radiotherapy is a photon-based radiotherapy. Please try to understand this. It's a photon-based radiotherapy. Now, what's a photon? Photon is nothing but a packet of energy, like an X-ray, like gamma rays. X-rays and gamma rays are photon-based radiotherapy. Now, they follow what is called as inverse square law. Inverse square law. What's an inverse square law? Inverse square law is that the intensity of the radiation will keep on decreasing as you go away from the source. Intensity of the radiation will keep on decreasing as you keep on going away from the source by the square of the distance. By the square of the distance. For example, if this is the X-ray source, this is point A. This is point A and this is point B. The radiation at point A will be much higher than the point B. Okay. On the other hand, the particles, they do not follow inverse square law. Now, what particle does is, if a particle is traversed through a particular tissue, it gives some of the energy to the tissue, and the energy transfer to the tissue is directly proportional to its contact time, and the contact time will be inversely proportional to the velocity. That means if a particle is traveling through a faster speed, it will transmit or transfer less energy. If it is traversing through a lesser speed, it will transfer more energy. If this is plotted on a graph where x-axis represents the distance and the y-axis represents the energy transferred, the graph is going to be something like this. Where this is the source from where the particle started and this is the place where it has come to the rest. This curve is called as Bragg's curve. Bragg's curve. And the peak of this is called as Bragg's peak. So it is to be noted that the Bragg's curve is a marker of particles, and this Bragg's peak is most pronounced in proton. Bragg's peak is most pronounced in proton. And what is the significance of the Bragg's peak is that, let us say your tumor is 10 centimeter deep. So you accelerate your proton and let it get stopped within the center of the tumor, which is 10 centimeter. So all the energy will be given to the tumor and the surrounding tissue can be prevented. And the surrounding tissue, that the damage to the surrounding tissue can be prevented. And this is the basic concept of proton beam therapy. It's a basic concept of proton beam therapy. Please remember, it's a very specialized form of radiotherapy which few years back was not available in any part of the India. But nowadays, Apollo Chennai was the first institute in the India which started the proton beam therapy. Apollo Chennai was the first institute, and I think the second institute which started the proton beam is ACTRAC Navi Mumbai, which is the center for it's a cancer hospital with Tata Cancer Hospital. I think, I'm not 100% sure, but I think ACTRAC has another proton beam therapy center. But the first center in India which has the proton beam therapy was Apollo Chennai. Okay. Alright, so this is a topic which is bound to be there in the exam, and that is the image of the HSG. And OBG people often give you an image of the HSG in the paper. It can give you a normal HSG, it can give you some disease HSG. So first of all, how will you identify an HSG? You will identify an HSG by looking at the opacification of the uterus along with the fallopian tubes. So this is definitely HSG. But now my problem is all the options are HSG. Then how will we identify that what HSG is this? Look at the background. If the background has a radiograph, All this is an X-ray now. If the background has a radiograph, please remember it is a conventional HSG. If the background has a radiograph, then it's a conventional HSG. If the background is made up of CT image, then it is a CT HSG. If the background is made up of CT, then it's a CT HSG. And obviously MR is MR HSG and USG is sorosalpingography. So this is a radiograph. So this is nothing but a conventional HSG. This is nothing but a conventional HSG. Please remember, you have to know an HSG images. So let me show you some of the HSG images. Anybody who can quickly in 5 seconds give me the diagnosis of this image. It was Neet 2020 image based question. Neet 2020 image based question. What is this? Bilateral tubes are markedly dilated. So this is a typical image of a bilateral hydrosalpinx. A typical image of a bilateral hydrosalpinx. Bilateral hydrosalpinx. Whereas what is this? What is this? Okay, let me give you the choices for this. Okay, unicornuate uterus, septate uterus, fimbrial block, cornual block. Tell me what is the answer. Unicornuate uterus, septate uterus, fimbrial block, cornual block. What is the answer? So the uterus looks pretty normal to me. The left fallopian tube is very well seen. I can see a splay on the left side, but I don't see the right fallopian tube. That means right fallopian tube is right blocked over here. And this is an image of a what? It's an image of a what? Yes, anybody? Cornual block. It's an image of a cornual block. All right, what is this? I don't see the other horn. So this is a unicornuate uterus. This is a unicornuate uterus. You're seeing only one fallopian tube and only one cornua. So this is a unicornuate uterus. All right. This is another image that the examiners are very fond of asking, and that is identification of a vessel on an image on CT or on angiography. Though I have explained it a lot of time on a lot of my YouTube videos, but just remember, I don't want any of you who have interacted with me ever to miss this. So please remember, I call it as a line versus dot principle. Okay, line versus dot principle. Now, what's a line versus dot principle? Line versus dot principle is very, very simple. And that is, if, please try to understand, it is, if a vessel is vertically oriented and you take a transfer section, if a vessel is vertically oriented and you take a transfer section, it will be seen as a dot. If a vessel is horizontally oriented and you take a transfer section, it will be seen as a line. This will be on a transfer section of the CT. This will be on a transfer section of the CT. For example, if I take a transfer section of the abdomen, IVC will be seen as a dot. Abdominal aorta will be seen as a dot. Renal artery will be seen as a line. Okay. So this is when there is a transfer section or a cut section. If it's an angiographic image, the only way to identify the vessel is look at the anatomy. So abdominal aorta, it's an abdominal section. Abdominal aorta gives three important branches: celiac trunk, superior mesenteric artery, and inferior mesenteric artery. If it is celiac trunk gives one major branch, which is hepatic artery proper over here, and on the left side it gives splenic artery. Whereas superior mesenteric artery traverse like this. So look at the anatomical orientation of the vessel. If the vessel is originating and bifurcating like this, it is likely to be celiac trunk. If it is projecting downward, it is likely to be superior mesenteric artery. So what is it? It's a superior mesenteric artery. It's a superior mesenteric artery. Okay. All right. That is how. If the vessel would have been gone here, then this would have been a splenic artery. If the vessel is going toward that, then that would have been. Okay. Now, what is this structure? What is this structure? What is this marked structure? What do you think? Now, it's a line or a dot. So, this is a dot. This is a dot. The dot on the left has to be aorta. The dot on the right has to be IVC. The dot on the left has to be aorta. The dot on the right has to be IVC. So, this is inferior vena cava. Inferior vena cava. So broadly, there is no limit on to the things that I can teach you guys, but all I want to say is this is how the standard questions of the radiology are asked in the exam. Question from the radiation, question from the contrast, question of the anatomy linked with the radiology, question of the anatomy, question of the medicine linked with the radiology, question of the OBG linked with the radiology, question of the orthopedic linked with the radiology. Try to pick them up. Please have confidence on your preparation. Don't give too much stress to yourself at this time. You people have done a lot of hard work. As I told you that I will pray on your behalf from Lord Venkateshwara that whatever effort that you have done, it should bring some fruit. Once again, I am telling you that you people have done your hard work. And that is the only thing that is there in our hand, and that is to work with the honesty, sincerity, and with determination. Let's give our best attempt in the exam. Just do this promise to yourself that whatever that I have covered, I will try to utilize it. I will try to give my best in the exam. I will pray on your behalf that whatever hard work that you have done should bring some fruit to you. Okay. So with this, I'll stop for the day, and thank you very much for attending this session, and may God bless you all. I wish you all the best for the exam ahead, and I'm sure that all of you will get the result that you're looking for. Okay, take care and all the best.